So again, I find myself between you and coffee. So again, I'll try to keep it short and concise. And I've got the topic of pericarditis and myocarditis to try and demystify for you. So I'm going to talk about the two conditions and then look at the different management approaches in aircrew between some of the NATO countries. And I'm grateful to Ed and cardiologists from the different countries for their input in this. But first of all, I've got a question for you. So in uncomplicated pericarditis, and uncomplicated is the important word, first line treatment should be A, non-steroidal anti-inflammatory drugs alone, B, creation of a pericardial window, C, steroids alone, D, non-steroidals and steroids together, or E, no treatment is required at all.
Okay, I'll close it off there.
Okay, so we've got a little bit of uncertainty there, so I'll see what you all think at the end. So I'm going to start with pericarditis, which, as you might imagine, is inflammation of the pericardium, and it's the commonest pericardial condition, although we don't have any particularly clear prevalence or incidence data. The figures that we do have suggest that it accounts for approximately 1.1% of hospitalised patients, and of patients presenting to the emergency department with non-acute MI chest pain, it accounts for about 1 in 20. It is commonly associated with viral infection, although routinely now we don't necessarily do serology to establish that completely. And it's usually diagnosed on the basis of having 2 out of these 4. So typical chest pain, a pericardial friction rub, ECG changes, and a new or increasing pericardial effusion. Importantly, from the point of view of our aircrew, the chest pain may be severe and incapacitating. It's usually a fairly typical paralytic sharp pain, which increases with inspirational coughing. Again, it's very classically described as being relieved by sitting forward because it takes the pressure off the parietal pericardium and decreases the amount of discomfort that way. Importantly as well, associated effusion may result in hemodynamic compromise. If you've already got an effusion that is impairing your return to the right side of the heart, then if you then are doing your anti-G straining manoeuvres, then you may further decrease that, and that can cause significant problems. It also brings with it the possibility of recurrent disease, and with that constrictive pericarditis, which is not a benign phenomenon. Arrhythmias with pure pericarditis are uncommon and suggest that there is in fact underlying heart disease or myopericarditis. If you have straightforward, uncomplicated pericarditis, so there's no effusion, no associated troponin rise to suggest that you've got myocardial involvement, then you should just be treated with non-steroidal anti-inflammatories, and that's usually for 6 to 8 weeks. And for patients who don't get that treatment or don't complete their 6 to 8 week course, data suggests that between 15 and 30% of those patients will go on to get either recurrent or intractable pericarditis. And those complication rates increase if people are treated with steroids in uncomplicated, straightforward idiopathic or viral pericarditis. So although the use of steroids is not described as a risk factor, it can certainly increase your complication rate, such as significant effusion, but risk factors for recurrent disease are associated with you failing to respond to straightforward non-steroidal treatment, if you do go on to need steroids, and if you are inappropriately managed with pericardiotomy or creation of a pericardial window. So essentially if a small area of the pericardium is opened up to allow for pericardial effusion to drain. Myocarditis then, not surprisingly, is inflammation of the myocardium, and again is most commonly recognised as being due to a viral infection and occurs in a clinically evident form in about 1 in 5,500 patients after they've had the smallpox vaccination. Has a very wide clinical spectrum, but most commonly presents with chest pain with or without dyspnea. Also, usually bloods will demonstrate raised inflammatory markers and a troponin release. And some of those troponin releases can be really very big, greater than 50, the kind of size troponin release that you would most classically associate with a significant myocardial infarction. And again, they may also have significant ECG changes. There is a big subclinical population, and this is quite well illustrated by the fact that about 1 in 200 patients who've had the smallpox vaccination have been shown to actually have a troponin release, but only 1 in 5,500 actually develop a clinically evident syndrome. So it is difficult to know how big this problem is. And in order to prove the diagnosis of myocarditis, histology by right ventricular biopsy is still considered the gold standard. You won't be surprised to know that that doesn't happen very often. The use of cardiac magnetic resonance imaging, particularly with some of the newer imaging sequences, is developing quite rapidly and is useful not just for diagnosis but also follow-up. And we're able to demonstrate quite clearly in many of these cases significant edema such that the myocardial mass may in fact double in some of these patients, and also fibrosis using late gadolinium enhancement. There's some pictures that for once aren't black and white. These basically demonstrate edema, thickened myocardium, and also some of the late gadolinium enhancement in the lower panels there. Concerns associated with it, with the potential for developing dilated cardiomyopathy subsequent to that, or in fact heart failure at the time of the myocarditis itself. And your risk of going on to develop a DCM is associated with significant sustained exercise at the time of the myocarditis. May also cause sudden cardiac death. And in an autopsy series of patients with structurally normal hearts, 22% of patients 22% of deaths in those under the age of 30 were attributed to myocarditis, and 11% in those between the ages of 30 and 40 years. And there are some data in military recruits to say that 20%, 1 in 5, of sudden cardiac deaths in the presence of a structurally normal heart was associated with myocarditis. From the point of view of managing aircrew with myocarditis, it can be really difficult to establish when it has fully resolved, especially if they only have very mild symptoms. And treatment isn't aimed particularly at the myocarditis itself, but more at the complications of it, such as heart failure, dysrhythmias, and when it's fulminant, at the management of cardiogenic shock. It can be particularly aggressive and can go on to cause significant heart failure that can require either ventricular assist devices or in fact cardiac transplantation. So what's myopericarditis or perimyocarditis? Well, essentially they're the same thing and suggest that there's evidence that both processes are going on. Now, they do say that depending on which way round you put your myo or your peri, might suggest which is the predominant syndrome. So if it's myopericarditis, the pericarditis is the predominant one, or if it's perimyocarditis, that the myocarditis is more predominant. But in reality, it just says that both things are going on. So how do we approach this in our aircrew? Well, in the UK, our policy simply states that aircrew are to be grounded until full recovery is confirmed. But as I've already said, it's very difficult to establish when that full recovery might be. Is it just when the patient feels better? Do we wait until we're absolutely sure that there's no further changes on ECGs? So, we are faced with quite a difficulty with these patients. And to make it even harder, we don't have a specific policy for pericarditis. In reality, we use Holter monitoring, exercise testing, and transthoracic echo routinely, and we want to make sure that those are normal before we would be happy to return the patient to flying. And as I said, we increasingly use CMR, especially in patients which have some features of more complicated disease. But what we're faced with, as we are able to image people more sensitively, is what is the clinical relevance of some of the potentially minor abnormalities that we can see on some of our imaging techniques. Some of the changes that we might see on cardiac MRI scanning, we would potentially consider to be normal if the patient was having the scan for a different reason. So it can be very difficult then to say whether or not that has a long-term implication for that patient, just because we happen to know that they've had an episode of myocarditis. And at what time intervals do we image these patients? So the Dutch approach for uncomplicated pericarditis is to ground their aircrew for 3 months and await the return of a completely normal echo and exercise test. But if they have evidence of more complicated disease, and they've got evidence of myocarditis, or if they've got effusions, then they're grounded for at least 6 months. And they also look for evidence of connective tissue disease and will go on to undertake cardiac magnetic resonance scanning in these patients. The Germans, as we might gather from earlier presentations today, do have a much more in-depth approach to this. They will ground their aircrew for 3 months after their symptoms have resolved, and they will also undertake magnetic resonance imaging to look for scarring. Monthly Holter and echo monitoring are used, and they'll do 3 24-hour Holter monitors followed up with a bicycle stress test at the end of the 3 months. And if all of those things are satisfactory, then they'll return to flying their fixed-wing non-fast jet crew, but will restrict their fast jet pilots for 6 months and may undertake centrifuge or chamber runs. The United States Air Force again will ground their aircrew for uncomplicated pericarditis, but will ground them initially for a month, again after their symptoms have resolved. But they may be on an approved non-steroidal at the time that they have their waiver submission, so that they can continue their 6 to 8 weeks of treatment in order to make sure that they complete those. Because aircrew typically will of course only want to take the medication for as long as they feel that they really have to, and if they're then feeling fine, will just go on to stop it. But that will of course put them at increased risk of recurrent episodes. In complicated cases, though, the United States Air Force will watch the patients for 3 months and will also do viral titers. As I've alluded to, pericarditis after smallpox vaccine is not uncommon, but it is established to have a relatively benign course, and so echo and Holter monitoring are undertaken after 6 weeks, and they won't restrict them further if they're normal at that stage. But there are some grey areas. How big is the problem? How many patients do we have with this? We've got quite a big subclinical population, almost certainly, and how do we know that they don't necessarily have the same changes on imaging that we see in those patients that come to our attention? What constitutes full recovery, and at what stage can we all confidently say that we're happy for them to return to flying, bearing in mind this has a very variable course between patients? And what's the clinical significance in the long term of minor changes on magnetic resonance in those patients who have completely normal imaging at 6 months? Is their outcome better than those who have some small areas of potential fibrosis at the same time period? So brief whisk through myocarditis and pericarditis, and so you can vote again and see what your answer is now to the same question I posed at the beginning. Once we've got the voting open. Oh, you're very enthusiastic. Clearly desperate to get to coffee. Yay. I seem to have demystified it for you satisfactorily. There we go.
Excellent, thank you so much.